Okay, Chapter 15. Chapter 15 is reassessment. This is kind of the summation of the assessment chapters, although there's a little bit more that goes along in this section when we talk about things like critical thinking and communication and documentation, so on and so forth. But reassessment is kind of the summary or the takeaway that we've picked up on what we believe we're going to pick up on, and we're going to continuously reassess that. This used to be called the ongoing assessment, and I like that term. I like ongoing assessment simply for the fact that it helps you think continuously doing this. It's a relatively short chapter. We have just a very few objectives that go along with this chapter. Couple of multimedia videos that you can look at in the non-lecture PowerPoints touching on ongoing and detailed assessments. Our core concepts, how to perform our reassessment, the significance of changes in vital signs over time or trending, the difference in the reassessments of stable versus unstable patients. So reassessment. This continues on the initial steps of the assessment, and it identifies changes and trends. Remember I said trends, we've been mentioning trends for a few chapters now. And trends are things that we see as we continuously are taking more and more sets of vitals. We're going back and looking at things over and over. We're seeing, are they staying the same? Are they getting better? Are they getting worse? And that's what that trending is. So reassessment often means looking at the things that were incredibly important, the findings that we found that were of concern. We redo our initial assessment, or our primary assessment. We redo our primary assessment each time we do a reassessment. Remember, it only took us less than 60 seconds to do when we started. It should take us even less time the second, third, and fourth times around. We're going to look at any things that have changed as far as vital signs. Did the vitals get better? Did the vitals get worse? We're going to look at things that we did as treatments and see if anything has changed. Sometimes we have very subtle changes, which if you weren't paying close attention and noticed that over time, over 3 or 4 sets of vital signs now, that blood pressure is just very slightly dropped each time. And if that's the case, by the time we go and we consider first set of vital signs and the fourth set of vital signs, there's perhaps a fairly large change now. Some of them are very profound. You might have the first set of vital signs be 120 over 80, and the second set of vital signs is 80 over 40. That would be obviously very profound. You'd be quite concerned. Communicating with the patient is critical as well. We're going to ask them to let us know how things are changing. Is their pain getting better? Is their pain getting worse? Can they breathe easier? So on and so forth. Explain processes that were to the patients. So if we're going to put an oxygen mask on, tell them, I'm going to put some oxygen on you. Might feel a little funny on your face or tickle inside your nose a little bit, but it's going to help you with your breathing and your circulation. Consider that patient's feelings. A lot of times they're very anxious. This is something they're not familiar with. We get anxious when we are very early in the field. We go on our very first several calls. We get extremely anxious. And understand that this is just like going on the very first ambulance call for many of our patients. And they may be embarrassed. A seizure patient who loses control of their bowel or bladder. They may think the whole world saw what happened, and they just really don't know. So we have to consider those things. So we recheck the life-threatening problems. Anything that we identified as a potential threat, we're going to double check, reassess their mental status, their airway, their breathing, their circulation. And I'm not going to go into the specific ones that they list here. Reestablish our patient priorities. So did we originally say, oh, our patient was not critical, and so we had time, but now all of a sudden, after after doing a recheck in 15 minutes, we determined, oh, this patient's gotten really sick. Patient's unresponsive. We may need to change our priority. It can go the other way as well. They may have originally started out as being critical, but now we reassess them and we determine, no, they're doing okay. Rechecking vital signs. So we're going to change our results, compare those results with the baseline measurements. Maybe we put them on a pulse oximeter. We had a patient short of breath who had a respiratory rate of 36, and their pulse oximetry said 85%. And we put them on a non-rebreather, and now their respirations have come down to about a 24, and their pulse oximetry is now at 95%. That's market improvement, and it shows, hey, what we're doing is doing something right. And we document these appropriately. And hopefully, as we continue to write these down and recheck them and go back and reconsider our numbers, we find more and more, hey, this is doing good, this is not doing so good, or we're seeing really no trend. So what's an example of a problem that might develop into a life threat to the patient on the way to the hospital? Probably one of the biggest ones that would come to mind is you go for a patient who's bleeding. Maybe they're bleeding internally, and initially they're doing just fine. And as time goes on, their blood pressure starts to go down, their heart rate starts to go up, and they start to become more anxious or even unresponsive. So by trending, by reevaluating their mental status and their pulse rate, their blood pressure, those are things that we're going to say, hey, we're having some deterioration. We're going to repeat our focused assessment. So the things that we picked up on before in regards to either their chief complaint or our quick head to toe, we're going to check those things again. So we'll look and see, do they still have blue fingernails? I mean, do they still have cyanosis in their fingernails, in their nail beds? Or has that improved? Are they still showing signs that they have lots of fluid buildup in their ankles? And in most cases they will. It's not something that typically changes immediately. Is their abdomen still very rigid, or has it now all of a sudden become soft? Ask about any changes in their symptoms and anticipate what these changes might be. So we'll take, for example, if we have a chest pain patient that we would give a nitroglycerin to, we would expect their chest pain to decrease. But there are also some adverse or some unintended, untoward effects that we might see as well. They might complain of a headache or some burning under their tongue, feeling a little lightheaded. Their heart rate might start to go up, and that's just something that goes along with those certain types of treatments. Repeat your physical exam to identify any changes from that baseline, and then recheck any interventions. You put a patient on a non-rebreather, and maybe your oxygen bottle that you started with only had 800 psi in it. You put them on this non-rebreather for 20 minutes. You're going to run out of oxygen. So recheck your bottle. Is it recheck the mask? Is there still oxygen flowing in it? Is there still pressure in the bottle? In the case of a trauma patient, maybe it's we check the bandages and the dressings that we put on, and now the blood is soaked through them. So obviously they're not being efficient anymore. We recheck any splints we would put on because we want to make sure it's still immobilizing what we intended it to immobilize. So just some examples of focused and physical. Again, are we doing a good job delivering oxygen? Are we doing a good job ventilating the patient? Do we need to change? Did our oral airway work initially, but it's not working so well now, and we need to think about putting in a king? Did we put them on a nasal cannula before, and their saturations just never got where we hoped they'd get to, so we need to switch them to a non-rebreather? So there's lots of different things. We check somebody checking a pulse while we're doing chest compressions on a patient. Checking a pulse while doing chest compressions, a lot of times there will be there'll be a weaker than normal pulse, but that pulse is telling you, hey, circulation is happening, blood is moving around and around. So describe an example of intervention that might need to be reevaluated and discuss your process for examining it. I think you guys can figure that one out. We've kind of talked about that. Observing trends. Repeat assessment steps frequently. We tend to repeat our assessment on stable patients every 15 minutes and unstable patients every 5. That's just kind of the rough ruling. If you have the hands, you can certainly do this more often. When you're starting to see trends, blood pressure is dropping, heart rate's going up, respiration's going up, saturation's going down, those sorts of things you pay attention to. With only one set of vitals, you'll never see a trend. So that's why 2, 3, 4 sets of vitals. You should really try, unless it is a no transport patient. If you put that patient in your ambulance and take them somewhere, you should have no less than 2 sets of vital signs on your patient. Even though it might be a 5-minute trip across the street, you still need to get a second set of vitals. So trending, just this slide just tells you kind of the definition of trending. And these can indicate whether things are going well or not going so well. Do we need to change our treatment, or hey, it looks like our treatment's working, let's leave it alone. So patient condition and the length of time with the patient will determine how often you reassess. If you've got an extended transport time, that 5 and 15-minute rules work. If you have a shorter transport time, you may have to shorten those up. This just goes back on your 15 and 5. If you believe there may be a change in the patient's condition, repeat at least the primary assessment and the vital signs real quickly. If you see a sudden marked change, that might be a good time to do your reassessment or to do a reassessment. Video on ongoing. So comparing assessments. Our stable reassessment, stable medical. Repeat the primary, repeat the vital signs, repeat the pertinent parts of the history and physical exam. You probably don't need to repeat things like past medical history because it probably didn't change. But if you think of something that they didn't indicate one way or another, you certainly could clarify at that point. But really looking more at the OPQRST things is what we're trying to get out of that. Recheck the physical exam, things that we were concerned with before. Check the interventions and do this every 15 minutes at least, if not more often if need be. An unstable trauma patient reassessment. Repeat primary assessment. Check for life threats again. We're constantly doing that. That's the one real standard there. Repeat and record vital signs again. Repeat trauma assessment, or your focused exam basically. Check your interventions that you performed, and then repeat these every 5 minutes at least. Another video for our chapter review. Reassessment is the last step in the assessment of your patient, yet it's not the end of the assessment because the assessment continues as long as we have the patient. You should reassess a stable patient at least every 15 and unstable at least every 5 minutes. Elements of reassessment include your primary assessment, vital signs, pertinent parts of the history and physical exam, and your interventions that you perform for your patient. Talks about interventions. Remember that to assess the patient condition, it's changed anyway, indicating there's need for new interventions. Is their airway remaining clear? Is their breathing remaining adequate? Is their circulation still intact and good? Or is this something we need to change? Do better, do more, do less. Sometimes we need to do less. Check the interventions you performed and are they functioning like you expect? Adjust as needed. So some questions for you to consider. Name the 4 steps of the reassessment and list what assessment you would make during each step. Explain the value of recording or documenting your assessment findings and explain the meaning of the term trending. So our critical thinking question for this chapter: what must you do if your reassessment turns up one of these findings? Gurgling respirations. Bag on the non-rebreather collapses completely when the patient inhales, or snoring respirations. Well, gurgling respirations means there's something in their airway, so we need to suction and clear their airway. Perhaps we need to start ventilating that patient. The bag on the non-rebreather collapses completely when they inhale. This happens with patients not getting enough oxygen into that mask. We may need to turn up the liter flow of the mask. We maybe have run out of oxygen in our bottle, and we need to switch the bottle out or switch to the house tank. Snoring respirations. They go to snoring respirations. That means they're no longer controlling their own airway. We probably need to do some manual things, whether it's a head tilt chin lift or a modified jaw thrust. Perhaps need to think about putting in an oral or nasal airway, starting some oxygen, and potentially ventilating that patient.